Welcome to another episode of the Fertility Podcast. I'm Natalie Silverman, your host. This podcast is to educate and empower you on all areas of fertility. And I wanted to just welcome you if you found this podcast for the first time. This one is going out at the start of Fertility Week in the UK. And there's loads of different exciting things happening. So please do subscribe to the podcast. You can rate and review, subscribe and share it to help shout about what you've been listening to if it's helped you in any way. One thing that people have been talking about for a while in the UK is that there's currently a 10-year storage limit if you freeze your eggs, which is slightly ridiculous when, say, you've decided to store at 25 and actually at 35 you're then going to have to get rid of them, and 35 might not be quite when you're ready. Maybe there's like a bit that you need to sort out still and you want to wait till you're 36. It's insane that you've been proactive and preserved your fertility to then have to let them go. The Progress Educational Trust has launched a campaign for Fertility Week. It's called Extend the Limit. That's the hashtag. And what they're doing is calling on the government to extend the limit. I mean, to put it into perspective, the number of women freezing their eggs has tripled in the last 5 years. The annoying thing about the 10-year limit is if you know you've already got 10 years, then you might wait later to freeze your eggs, which means that your egg health has declined. And what we know is that if you're going into fertility treatment in your late 30s or 40s, when maybe that's when you've frozen your eggs, you need more ovarian stimulation and the cycle is less likely to have success. So you want to freeze your eggs early to get the best quality eggs. Then you don't want to have this 10-year limit. Doesn't make sense. Hence the petition. So, like I say, all the details will be on the show notes for you to go and sign. And that hashtag to keep an eye out is Extend the Limit. And Fertility Network UK are using the hashtag You're Not Alone, as well as Fertility Week. If you're blogging or sharing anything that's going on in your world, every day this week there is going to be so much going on. Fertility Network, I've got a hashtag for every day. Today, it's Mental Matters. And they're going to have Kelly De Silva talking about tips about your mental health. Claire Rahim as well. I will be putting some links to my chat with Kelly because she gave some amazing advice about living a life childless. Tomorrow, Tuesday, Fertility Network are focusing on fertility in the workplace. And as you've probably heard, if you follow Alice Rose on Insta, Alice has done something pretty amazing in that she pitched an idea to BBC Radio 2, which in the UK is the biggest radio station, to do some features on fertility. And I don't know whether she went in pitching a week, but a week is what we're going to get. The BBC are focusing all week on different stories about fertility and infertility. And what they're doing on Tuesday, so tomorrow if you're listening in real time, that's the 29th of October, is they're linking up with BBC 5 Live, and what they're doing is like a network-wide fertility day, and they're going to be talking about all different aspects in terms of creating families, looking at issues in the BAME communities, embryo adoption, fertility in the workplace, male infertility, lots of different conversations happening, and it's going to be a brilliant spotlight that's being put on fertility conversations. It'd be interesting to see how it goes and what people comment back. People calling in, people get quite irate when they get in touch with radio programmes. I used to work as a radio presenter. I know how personally people take these conversations. So if you are able to, do make sure you've got either BBC Radio 2 or BBC 5 Live on tomorrow, because there is going to be no doubt lots of conversations going on. The website for you to find out more is bbc.co.uk/fertility, and also BBC Sounds are going to feature a highlight package from both of the networks, which is the app, if you haven't yet got, that you can download. Loads of cool stuff to listen to. Again, I will put the link to that in the show notes for this episode. It's going to be a very lengthy. Going back to what's happening with Fertility Week, on Wednesday, the hashtag is Men Matter. Now, you'll know if you've listened to this podcast at all in the past, I put a massive emphasis on trying to encourage men to talk, and I will be sharing more of that content on Wednesday for you to catch up. Fertility Network are going to be sharing clips from the Easy Bit documentary, and I voiced the narration for that, and I've caught up with Tom Webb, so I'll be, of course, sharing links to Tom's conversations and reminding you about the Male Only Facebook group, how you can learn more about that. Thursday, 31st of October, the focus is on fertility education. 71% of young people aren't aware of the lifestyle factors that could affect their fertility. And there's going to be lots of information shared from the Fertility Education Project, which is the hashtag for it is Future Fertility. And there's also a guide that's been created by Cardiff University. So I will be sharing more of that too. Then Friday, Saturday, Sunday is the fertility show, which you know I've harped on about a lot. So just keep an eye on my social media channels to stay up to date with what I'm sharing from relevant content, because all of these topics are things that I've covered in previous episodes. So I'm going to be linking back to other conversations that I've had. And it'd be really cool to hear from you because, of course, whilst this week is amazing, our experiences and our challenges and our struggles don't stop in this week, and that's what this podcast is for. So if something that you see or read or hear triggers something this week and you don't get a chance to talk more about it, don't forget the Fertility Podcast. You can follow me at FertilityPoddy on Twitter and Insta, and also you can drop me an email, natalie@fertilitypodcast.com. It's always really great to hear from you. Right, without further ado, we need to get on with today's episode. What you're going to hear today is the first episode of a soon-to-be launched brand new podcast called the Agora Journals. It's a project that I've been really chuffed to be involved with, working with the Agora Clinic, who work with such a diverse community that they wanted to capture the community and make it into a podcast series. So this first episode is a conversation I had with clinical director Carole Gilling-Smith. And you'll hear Carole talk about all the different people that she works with and her kind of intentions for wanting to spread the word about the people that the Agora help to start a family or help to find out more about their fertility or help to preserve their fertility, because it's so important to educate, as we know, and also reach out to people who might think that due to life circumstances, parenting might not be an option. And actually, just hearing how it could happen for you could be just what you need to know. So I hope you enjoy this episode. It would be ace if you could rate and review, subscribe and share what you hear. And at the end, you'll hear details of how you can also sign up to subscribe to the Agora Journals so you won't miss that once it goes live. Welcome to the Agora Fertility Journals, where we talk about empowering the freedom of reproductive choice for everyone. I'm Natalie Silverman, host of the Fertility Podcast, and the Agora invited me to visit them in Hove, where they support a wide range of individuals and couples on their route to parenthood with wisdom, compassion, and honesty. This podcast series is all about their stories, dreams, and actual journeys to parenthood. The Agora Journals. We hope you enjoy them. In this first episode, Clinical Director Carole Gilling-Smith explains her motivation for setting up the clinic, her love for education amongst young people, and the wide range of work the Agora does for its community.
I really believe that we have to start fertility education very young, obviously in schools, but also there's a range of places where we can put fertility education into society when people are in their 20s even, not necessarily thinking about having children, making people a little bit more aware, fertility aware of their bodies, aware of the biological time clock, aware of some of the toxic substances that may be harmful.
Carole has been developing a strong support network for the LGBTQ community, ensuring everyone is supported in their experience of fertility treatments, whether they're looking to preserve their fertility for the future or have a baby now.
I'm Carole Gilling-Smith. I am a consultant gynaecologist and I set up the Agora in 2006. It came from a desire to set up a perfect fertility clinic, which we all set out to do. I had been in fertility for nearly 20 years and it was my passion to be able to offer patients the sort of journey that I would want to experience if I was a patient. So a very caring journey, and a journey where I could feel as a patient that I was listened to and that I was treated as an individual. And it came from that, and I decided to come down to Sussex, where I was already living, because there wasn't a clinic here. And right from the start, I wanted to have a very central involvement with the patient care. So I wasn't just managing a clinic or a business. I was going to be seeing patients and interviewing and appointing all the staff so that they could share my philosophy.
Now, I've come to spend the day with you at the Agora to capture some of the stories of the diverse patients that you work with, as well as talk to some of your staff. And we've spoken a lot about the emphasis that you put on fertility education. And you've been doing a range of projects. You're involved with Fertility Fest earlier in the year, and you've done work here at the clinic. Talk to me a bit about your focus on that education in the work that you're doing.
I think it comes to me naturally to educate patients, because so many patients come to me in their late 30s, early 40s, and you start to have a conversation about, why they're there, and you start to explain to them a little bit about their fertility. And whether it be women or men, I'm always quite shocked that they have so little understanding about their own body and their own limitations fertility-wise. And I really believe that we have to start fertility education very young, obviously in schools, but also there's a range of places where we can put fertility education into society when people are in their 20s even, not necessarily thinking about having children, making people a little bit more aware, fertility aware of their bodies, aware of the biological time clock, aware of some of the toxic substances that may be harmful. And I like to continue that into the groups of society for whom there isn't really a book about it. There isn't something that's been, easy to pick up and find out where to go next. One example is patients transitioning. There is so little out there for them to actually be able to read and say, this is proper information, I know where I'm going now. So the work I'm doing for that community really is to listen to them, listen to their questions, and try and put some of their answers into a format that they can understand, that a patient can digest and understand, so they can move a little bit further on in their journey of exploration.
Because that open dialogue is something that's been at the core of how you've developed, how you work with the LGBTQ community, in that you've asked for their feedback on what could change. And I know, for example, when I spoke with Satch, things like paperwork, pronouns used in paperwork that may be overlooked. And I hear from people, even, for example, if a woman is going down the solo motherhood route, she might be referred to as a single mum rather than a solo mum, which is such a subtle difference. So thinking of somebody transitioning and how triggering the incorrect pronouns are, the fact that you've been able to have that dialogue and has then enabled you to really develop what you're doing, hasn't it?
It has. It absolutely has. When I first came and lived in Brighton, and I realised there was a whole group of people out there who wanted to have children. They weren't infertile, and we had a standard fertility questionnaire, and it talked about the man and the woman, and it was offensive to hand that out. And I very quickly picked up from that community that we had to ask the questions. We had to ask them, what were they sensitive to? What would they like to see more of or less of? And I've done that with all the different groups in the LGBT population ever since then. I found that to be the best way of engaging in a dialogue, so that we can really offer a bespoke treatment to different groups of patients. My background, having come from London where I worked with the HIV population, had taught me, that HIV is a taboo word, and people feel really, they don't want to be feeling different to the rest of the people in the clinic. So you don't make a big issue about it. You don't have great big posters saying where are you? If you're an HIV positive person, we can help you. You keep it really quite subtle, and that's what we do with our LGBT patients. So when they come along, they are welcome into our fertility clinic, whatever their problem may be or not. They want to have a family just like everybody else. And one of the things that we did over the last 2 years was to completely scrap our old patient questionnaire, and we said, you're either a provider of eggs or you're a provider of sperm. And that came from one patient coming and saying, I'm non-binary. And it made us really think. None of our paperwork was really adapted. And now we're doing quite a lot of work on, careful use of the pronouns, so that actually it doesn't really matter who comes through the door. We've been sensitive to, how they like to be perceived and their gender identity and, what makes them them.
Whilst we're focusing on the trans community, one of the things that you and I had spoken about was the point in which fertility preservation needs to happen, and trying to get that message out to help, because I know that you've got experience. You've got a staff member here who wasn't aware of their options and made the transition and hadn't preserved their fertility, and that's a regret that they have to live with. So how would you explain that point of time that people need to be made more aware of?
Whatever gender you're assigned to at birth, we now recognise that it can be wrong, and that you can, during childhood, adolescence and early adulthood, come to realise your real gender identity is the opposite sex. And at whatever point that is, the probability is you will not have very much information about fertility. And that's where we think there's a big gap. So once you start to go to a gender identity clinic, you will have discussions about hormones that will allow you to move gradually into the sex that you wish to be. And whether it's testosterone or estrogen, it will have a damaging effect on your eggs and your sperm. So we need to be able to offer fertility preservation before hormonal treatment starts. So for a trans woman, the sperm that's being produced is perfectly healthy until such point as estrogen is started. And for a trans man, the cycle continues and the eggs are perfectly fine until testosterone is started. So we have a window of opportunity when the trans man or trans woman may have been living as a trans man or woman for some time but haven't started the hormones. We are starting to get more and more referrals because the gender identity clinics are realising this is a window of opportunity. And thankfully, we're starting to see more NHS funding of that transitioning process. So the NHS will fund fertility preservation in patients undergoing chemotherapy or cancer treatments, removal of testicles and so forth. They are now starting to fund this process, which is, I think, amazing. So we have to catch the people at the point where hormones are being discussed.
And am I right in saying that you've done some lobbying locally with regards to your CCG to have that funding?
We have, and it's literally just come through that we have funding in Sussex for transitioning patients to have their fertility preserved before they start hormone therapy, which is amazing.
And I know part of that conversation is about addressing a person's sexual orientation.
Yes, it is really, really important to open up a conversation about, if you are able to freeze sperm or eggs, how do you think you would want to use the sperm or eggs in the future? And it's inevitable. It's going to be different if you're a trans woman who has a relationship with another woman, or a trans woman who has a relationship with a man. And we therefore have to explore if the sperm is going to be used in fertilising an egg from a trans woman, or whether the sperm will be used in a surrogacy arrangement and fertilising a donor egg or the surrogate's egg in a surrogacy situation. The screening is different, but there's also an important conversation to be had about the potential for the fertility treatment to work and how it might work and how long it might take and the chances of success. That's really important to have. And I think it's also making that person really think a little bit about their future as a parent and how it might look, even if it's a long, long way off. It does mean that there are no regrets. At the point we have the sperm frozen safely in liquid nitrogen, it's been screened as required by current UK law to be used in the way that that person would want.
One of the things that has come up in some of the conversations that I've had today with Thomas and Michael talking about their surrogacy and with Satch talking about their future family was the story that is told to their child. And I'm interested in the support aspect of what the Agora offers people. Obviously, you're enabling these families to be created, modern families, which is what this remarkable science enables us to do. But then there's that story, and I know you've created a book, and it's the telling to the child of their story, and also to a family's wider community. How do you feel that we are preparing ourselves to help people tell their stories?
That's quite a big question to answer, because one of the things that I'm passionate about is opening up the conversation about fertility per se. So if a couple are comfortable talking to a friend or to a family member about the process they're going through, they will be so much more comfortable talking to their child, because that child will be growing up with their own story, and it's really quite a special and remarkable story to be wanted so much, to have gone through all these steps to be created. And I see this particularly with patients having gone through egg donation as well, very, very much so. So I think we are starting by trying to talk a little bit more about fertility. We are also sowing the seed of how important it is that once they have a child, they talk to their child from a young age, a really young age, that they start talking about their, who they are and how they came to be. And we introduce that through counselling as well. A lot of our patients will have implications counselling. It's not compulsory, but it's something we strongly recommend, particularly using donor sperm, donor eggs, or surrogacy. It's a very important part of the journey to really understand as a parent or as a future parent what your child might be asking you and how to convey those messages. And all the way through, we try to direct our patients to some resources, Donor Conception Network and other groups, to help them find the information they need. The first thing we have to find out from a trans man is there good fertility there, and can we preserve it? So the first steps would be to have an ideally internal transvaginal scan or transabdominal scan. Some trans men would prefer that, to see what the ovaries look like and to see if there are small follicles which contain eggs. And we would also do a blood test to look at a hormone called AMH, or anti-Müllerian hormone, which is a marker of egg fertility or egg reserve for biological age. With that information, we can give a fairly accurate idea to the trans man of the likelihood of being able to retrieve healthy eggs to freeze. And obviously we'd discuss with the patient their age and how many eggs would be ideal to freeze in terms of their age. We would also explain the importance of remembering that eggs on their own, frozen, are less viable than embryos, and we'd have that discussion about whether it would be sensible to consider putting donor sperm with the eggs to freeze embryos, which do have a better survival rate currently at the moment with our current research knowledge. So we'd look a little bit at sexual orientation, and if the trans man is orientated towards having a relationship with other women, donor sperm would be required to make children in the future. So it might be a conversation to have at that point. Should we consider getting some donor sperm and fertilising your eggs before they're frozen? Then we would sit down and plan the cycle, and I would talk very carefully through what that process would involve. Ideally, that would involve monitoring using internal transvaginal scans, but again, it can be for some patients difficult. So we'd look at the restrictions that are imposed when you scan somebody through the tummy. You don't see quite as clearly the ovary. We'd also talk about the actual process of retrieving the eggs, which is done under anaesthetic, and it's just they need to understand what would happen when they're asleep. We would scan internally for that process, and we would put a needle into the ovary to collect the fluid, and with that the eggs, and freeze the eggs. I think that given an overall picture, they would go away, have a little think about it, and then we would arrange for them to see a nurse, talk it through, get some dates in the diary to start the treatment and make sure that they were completely happy. We give them a lot of patient support at that point, and one of the things I am looking at is building up a community of buddies specifically to support people who have a little bit of apprehension about going through the process, so they can talk to somebody who's already been through the process. And then we would proceed. And I think the important thing that we do emphasise here is that if they've got any issues at all with internal examinations, they're going to be fine. And I think you've spoken to Jane. This is a clinic that takes that very seriously.
Jane spoke about it, and Satch spoke about it. And I think one of the interesting things that Jane raised was that despite sometimes when the sedation is in effect, that the body still reacts how the body reacts, which is obviously something as a clinic that you have to work around and explain to patients. But the fact that, again, the dialogue is there is
Yes.
reassuring to people, because that could be one of the hurdles to even stop them coming in the door, couldn't it?
Oh, absolutely. And I think that for many of the patients is this, what am I going to have to put myself through? And the reality is, I say to people, just come along and have a chat, because it may not be for you, but the probability is we'll be able to get round any sort of psychological issues you have about internal examination. Even if that involves taking some drugs that will help with anxiety, help to relax you, we will be able to help you, because a lot of it is the apprehension makes it worse. And as I'm sure Jane will have explained, is once you start to work with a patient, you can really encourage them to feel more relaxed and more confident that they will be able to do it.
Because there's an assumption that as a woman, it's something that you wouldn't have a problem with.
No.
Without the consideration of what being a woman actually means in the broader sense. I think that's
I think so. And I think if you have been living for a while as a trans man, the idea of a vaginal examination is one that may fill you with apprehension and unpleasant feelings, and therefore we have to be very sensitive to that. I think we can apply that to a number of other situations which are, which we'll find in lesbian women, we'll find it in women who have perhaps experienced sexual trauma in their childhood or in a past relationship. So we are very sensitive to that.
On the other side of the scale, we've got the treatment for a trans woman.
Yes, if you're a trans woman, it is important for me to talk you through whether you've gone through a normal puberty. So we are seeing more younger people coming through who may have puberty suppressed, and that's coming in. But the majority of patients I'm seeing will have gone through a normal puberty, which will have involved testosterone making changes on the body, and those changes are obviously deepening of the voice, facial hair, development of the testes, and the start of sperm production and the ability to ejaculate sperm. I always touch very gently on how do you feel about ejaculation, because to freeze sperm we are going to have to ask you to ejaculate. And sometimes we actually have a little bit of a laugh about it, and they'll say, well, does that mean I have to wank? Yeah, and we kind of just say, yeah, it's probably the best way of describing it, but that's what you will have to do. But try to think about it as your future fertility. Just think about this as a process that you're doing to be able to have children, and actually that will make it much easier to be able to do. And then we talk about the sexual orientation and how it's important to make sure that the sperm has the ability of being used in the future, and that we've done all the screening tests, and that all the consent forms are correctly filled out. And we obviously support a great deal the actual filling out the consent forms. They fill out the consent forms, but once they're fully informed of all the options. And then we generally get them to come in 3 or maybe 4 times to produce a sample. They can produce a sample at home, but as long as home isn't too far, half an hour, 3/4 of an hour away, that's absolutely fine. As long as they can identify that it's their sperm and write, and sign that. The process for freezing sperm in a trans woman is so much simpler than to freeze eggs. It is usually one appointment to see the doctor, talk it through, and then come in to do the freezing.
The work that you've done enabling this community to have access to treatment is so freeing for them. I was talking with Satch about being able to have the conversation about to the future child's grandparents, that there is going to be grandparents, in the same conversation with Thomas and Jason that they were able to have with their parents, that they were going to be able to provide them with grandchildren, which is such an issue for parents of gay or trans children. And I'm interested as well in how, as a clinic and as an individual, you're maybe finding the conversations are going with your contemporaries about the importance of this level of attention being put on this community with regards to the treatment being enabled and the support. Do you feel that more clinics are opening up to it and are getting their heads around the importance of enabling these communities, more so the trans community, because I know that's something that is a growing area of interest in the work that you've been doing?
I think it is important that it's normalised, it's normalising, and it's not necessarily fertility treatment, it's making sure that everybody has that chance of having a child if that's what they would like to do in the future, giving people the choice and empowering them with the knowledge that makes them give all the options consideration so they make the right choice for themselves and never regret, never go back and say, I wish somebody had told me this or that. I think there is definitely a movement in fertility clinics in the UK to open their doors to the LGBT population. Some clinics are doing it in a personalised way, as we are, and taking a real interest in their community. I mean, I love living in Brighton, and it's a vibrant city full of amazing people, all very different, and the LGBT community is just part of that colour that we have, and I embrace it fully, and I actually enjoy learning from that community what we can do better, and I really enjoy listening to them. So I think as the programs develop, they're very much shaped by what the patients tell us they'd like to see more. I've worked with non-binary patients, and that work has enriched my knowledge of how we should be communicating better and being more sensitive. And I think we've got some great work to do around surrogacy, because it's a fairly new area. A lot of patients who have previously adopted, gay couples who've adopted in the past, are now looking at surrogacy in the UK as a real option and not thinking, well, I can't afford it or I have to go to the States. And I think I've really enjoyed working, with the couples we've seen so far. Thomas and Jason are been just one of these couples where they've worked with me. They've come up to Fertility Fest. They've seen some of the really important work we're doing. Julie and Mike have done amazingly well to keep going in the way that they did, and thankfully they've got beautiful Finley now, and it's been a lovely happy ending to what could have been just a roller coaster of disasters for them. So Julie came to me, she wasn't menstruating, she came to me with a condition called hypergonadism, so her hormonal stimulation of the ovary was not working normally, so there was an element of putting that right. But she was also in an age group where fertility was starting to decline, and her husband had a vasectomy, so we needed to consider retrieval of sperm. And having discussed all the issues, we went ahead with an IVF treatment cycle. His sperm was retrieved and we used ICSI, and unfortunately that cycle didn't work, and we gradually moved towards the point where I had to say to Julie that I didn't feel it would work with her own eggs. Her fertility was very low, and we talked about egg donation for quite a while, really, and I think they'll explore that with you in a little bit more detail as to why they finally decided to go down that route and how they went down that route. But Julie's sister kindly offered to donate her eggs, and I met with her and we sat down and talked very openly about how the relationship would work. How would the child feel, with a donor that was Julie's sister, and you have to really explore all the what-ifs of the relationship between the husband and his sister-in-law and the genetic parent of their child. But it was clear that they were really, really close as a family, and they went ahead. The first cycle led to a successful pregnancy, but the child had multiple problems, and eventually I think the pregnancy ended, and it was a terrible, terrible moment for us and for Julie and her husband Mike. It was absolutely devastating, but we felt it at the clinic. We felt all of that pain. And when I saw Julie afterwards and she told me about the funeral of their baby, I didn't think she would get up off the floor. I didn't think she would actually be strong enough to keep going, but she did, and her sister offered to donate again, and it all went beautifully, but it was a long journey to get there. And I think I could sense it from the emails coming through during the pregnancy. There was so much tension. Will this really happen? Will the baby be eventually born? And will I be cuddling my baby? And it's been a wonderful experience to meet up with Julie and Mike and the little boy recently. It was quite an emotional moment for all of us, really. Unbelievably emotional, because Julie does actually say how this has transformed their lives in no other way that it's been a little miracle. And I do love my job, because every baby that we help to bring into the world is a little miracle. But some you really see have been true stories that you just didn't feel that could happen, and hers was one of them.
Because the expectation when it's a donor, especially a family member, is huge on both sides.
Absolutely. And the expectation was, it'll be fine. And when you get the pregnancy and it's a donor egg, you think, well, nothing could possibly go wrong now. It's all going to be fine. No, we were told that the chances of a pregnancy with a donor egg were going to be really high, and now we're pregnant and everything's going to go fine. And of course, when it doesn't, you just don't prepare yourself for that. I have seen a number now of sister-to-sister donations, and I don't think it can work for everybody, but if you have a close and loving relationship with a sibling, then it can actually be a really beautiful way of giving somebody something. I said to Julie, you will always find there'll be a time when you give back something, and it'll be when you don't expect it. It really will be. But I think for the child also, I think it is a lovely way of having been created, because you know that actually in that bag of genes that happens to be, if you like, your aunt genes, is your mother's genes. There's so much crossover that you are actually, it's as close as you can have to having had the direct genetic egg of your mother.
And there was a similar theme in the conversation that I had with Thomas and Jason about how they are now in a position where their surrogate might be a known family member, and through having the conversations of where they were at and what they needed, it enabled the conversations to happen amongst their family members. And I think that's a similar thing with Julie and her sister, that by sharing what's going on with your family, which a lot of people sadly don't do, it's enabled this development in their journey, and obviously an amazing outcome of a baby. Do you feel more people are opening up? For so long we know that a lot of people keep this as something that they're embarrassed about, that they don't want to talk to their family about, especially if it seems a fertile family and everybody around them is having success.
I think you're absolutely right that for a lot of the people I see, they would not open up that conversation with their close family members, either because they don't have that close and warm relationship, or they do feel that they wouldn't want their parents to know, or their parents-in-law to know. It couldn't possibly be right to tell them, and they keep it to themselves. But I think if you look at it, when it is a good relationship between family members, when you see the happiness that the giving is what brings a lot of happiness. Known donation, when you're giving something and you're giving it altruistically like that, it's a good feeling too. And I think the child, ultimately it's about the child. The child has been brought into the family feeling very loved, very loved.
One more question in terms of a gay couple coming in to go down the surrogate route, and we've got the story of Thomas and Jason talking about how they came into this so informed. But if men are wondering whether it's an option for both of them to have that genetic link to their future child, what's common? Is it common for both parties to freeze their sperm? Does one do it more often?
I don't know that there's an answer to what's more common. I think it's the same in a same-sex female relationship. Parenting may not be for both, but if it's on the cards that they would like at some point to be the genetic parent of the child, it's so much easier to assess them both at the same time and to consider freezing sperm at the same time whilst they're young and that they've got their best fertility, because you never know what might happen in 2 or 3 years' time and their fertility might decline. So what we encourage men to do in a gay relationship is perhaps really think about that question. Think about coming in and having some good in-depth male fertility screening, and then make some lifestyle changes if the sperm quality isn't maybe that good, and at the point where it's as good as it can be, to freeze their samples, and to freeze it obviously in a way that they can use it in a surrogacy arrangement. then the job's done. They can just relax and think about the future and come back and the sperm is there. So it is a sort of fertility preservation, but think about doing it at the optimum time.
Because one thing that Thomas and Jason said was that they were surprised that there were issues with both of their samples. It wasn't something that they'd ever considered. And whilst it hasn't prevented any further treatment, because we talked about how they were going to be having ICSI, just that awareness wasn't something that they had because they were saying they're both in their 30s and they assumed everything was fine. So it's that empowerment of the knowledge as well, isn't it?
It is, and it's the reality that male fertility is on the decline. There are factors in the environment, there are lifestyle issues that are affecting sperm quality, and it certainly wasn't the case, that neither Thomas nor Jason had particular lifestyle issues that I said, no, you mustn't do this or you mustn't do that. That just happened to be the quality of the sperm at the time. But knowing that, going in with the knowledge is so important.
And whilst we're just talking about that issue of male fertility, are you seeing an increase in poor sperm health or lower sperm counts?
Well, it's an unfair question to ask somebody who sits in a fertility clinic, because I really only see infertile couples. I'm starting to see more men coming through for surrogacy, so that I may change my opinion, but we are seeing a lot of male infertility that's quite subtle, but is often underlying an unexplained situation. And we need to invest a lot more in male fertility research so that we can really understand what exactly is triggering this.
Isn't Carole doing amazing work? And you can hear the Agora Journals once we go live. To make sure you know exactly when that happens, visit bit.ly/Agora Journeys. Pop in your details and we'll let you know once we launch. That is the URL for you to subscribe. If you're on the move and that's gone right over your head, then get yourself to thefertilitypodcast.com/Agora. And that's where the show notes will be. And I will put that link in there again. If you've forgotten that, then just go to the Fertility Podcast website, which is really just type it into Google and you'll find it. Make sure you follow me on my socials at Fertility Poddy on Twitter and Insta. The closed Facebook group for the podcast is Talk Fertility, where we're carrying on the conversation about what's being discussed in Fertility Week. So if you've got any questions about any of the topics going, and I'm popping in the group more and more to talk to you about the coaching work that I'm doing. So it'd be lovely to talk to you there. I will be at the Fertility Show this coming Friday, Saturday and Sunday. That's at Kensington Olympia in London. I'm hosting the Let's Talk Fertility stage, and again, if you're coming along, it would be so nice to get to say hello. If you're thinking about coming along and you're not sure if it's for you, I have shared a couple of episodes about what you can expect from some of the speakers. What I would say is that one thing to know about it is, if you might have been before and it was a little while ago, it's definitely changed. If the idea of going to a kind of exhibition centre to talk about this topic just doesn't bode well with you, it doesn't feel like that, because there's a lot of really caring people under one roof who just want to help you. What you can get access to is a lot of information in one place. So maybe if you've just started out on this exploration of understanding more about your fertility, and Dr. Google has been your friend, this is a way to talk to people. There's amazing people speaking in the seminars. There's also all the people on my stage, the Let's Talk stage. Jessica Hepburn's Fertility Fest is going to be there, again with an amazing programme. The details of the show will all be in the show notes for this episode. So go and have a look. And like I say, do come and say hello, because I'm going to have some stickers. Yes, I'm putting it on the podcast. I'm going to be attending the fertility show with some podcast stickers, because the podcast's now 5, and I thought, you know what, why not? Everybody loves a sticker. So yeah, that's a reason to come and say hi, isn't it? Thank you as always for your support, and until the next time,